I've had Zach sit here the whole time and not say a word, and I'm gonna get. I want him to chime in just a second, but I want to clear out two things. One, so if a patient's going to start a TZO-BEV, they need to get a screening endoscopy, right? And so they need to make sure that they don't have clinically significant varices. That's a barrier.
Right, they're not at high risk of bleeding.
By and large, immunotherapy is very well tolerated. What kind of oddball issues have you noticed with immunotherapy? Anything out of the unusual things to recognize, be aware of? I mean, obviously, we've seen some significant immune-related toxicities in the lungs, right? We've
in the liver. Hepatitis is common, actually.
Okay. Is there anything else to know?
I mean, it could affect any part of your body. That's the tricky thing. I think actually the liver one's the toughest for me because sometimes you're like, man, is this the beginning of like a immune-mediated hepatitis, or is this just their cirrhosis getting worse? Is this disease progression? Like there's the differential so broad there, and you're like treading a little bit carefully. Like, do I pull the trigger on starting steroids? Do I get set him for a biopsy? And our IR guys are very hard to get in touch with. So
thanks.
No, I'm just kidding. So obviously, so I think that actually can be a little trickier than pneumonitis. I feel like we're pretty used to diagnosing that and treating that, but I feel like the hepatitis gets really tricky, and the rates of those are reasonably high when you look at the studies. Now, I wonder if some of that truly is hepatitis because it's a clinical judgment. It's not. You're not getting biopsies in the majority of these patients to
You're just looking at AST/ALT.
Yeah, so sometimes it's like we call it immune-mediated hepatitis, but sometimes I wonder if it may not be. But that one's always very tricky for me.
And sometimes, we think of these more common itises as things that are relatively easy to treat, if you will. Colitis, even the hepatitis, the thyroid abnormalities are very common. But it is important to keep in mind that the more high-risk itises, encephalitis, cardiomyocytes, they can be fatal. And,
like pneumonitis.
Exactly.
Like people die from it.
So it is something that we are a discipline that tolerates an inherent amount of risk in medical oncology. It's part of the disease process of an advanced patient. But although generally speaking, most people are going to do well in immunotherapy, there are these rare birds, and including fatalities. So we have to be mindful of that.
Now, I've had Zach sit here the whole time, and now I can transition. I'm sorry you had to sit here the whole time.
No, this is fascinating.
I'm like, I would rather just sit and listen.
Yeah.
I want to talk about combination therapy because I feel like that we are making massive waves with combination therapy. I think we're seeing incredible outcomes. Part of my approach is if a patient, even in the early stage, if a patient has a big tumor or they have multifocal disease, they may not be in the BCLC category. They may not be BCLC-C or that far B. But if they're not going to go to transplant, and they might benefit from a dual phase approach, I think combination makes total sense in my opinion, assuming the patient can tolerate that. So I wanted to get y'all's take, and then I want to loop in Zach on how to tackle this. When do you make the decision on combination? When do you say, I want to not only just treat with immunotherapy, but I might treat with Y90? Or Zach, when do you say this patient would be great from a local regional, but immunotherapy might make total sense to boost an outcome?
So I'll start with data, and then we can devolve into what we actually do in real life. But the two trials that we know about were LEAP-12 and EMERALD-1, looking at the combination of TACE plus various forms of systemic therapy with immunotherapy and either bevacizumab or immunotherapy and lenvatinib. Both of those trials were technically positive. Their primary endpoints were progression-free survival, and we're still waiting in both trials for overall survival. And so we'll start there. Is that we do have some evidence that at least from a progression-free survival, TACE extends onto. Although I don't think we've treated one patient off trial with TACE in immunotherapy. So we've resulted to mostly Y90. And there are two trials open right now, ROWAN and then EMERALD Y90, both single-arm phase 2 trials to hopefully address that. But in real life, we're doing mostly Y90 in combination. I think there's a lot of reasons we do that. The first one is Y90 is just a better therapy than TACE. A little controversial, but I think true. But then also to a second degree, and you said it earlier, and I think perked my ears a little bit, is this concept of the tumor microenvironment. And can we alter the tumor microenvironment and figure out how we can potentially overcome exhaustion, as you said as well. And these are all just theoreticals right now, but we're starting to get a better understanding of how can we alter the tumor microenvironment, whether it be with radiation or some sort of ablation like cryoablation or electroporation, or other types of intraarterial therapies or percutaneous therapies like intraarterial immunotherapies, or percutaneous injection of like herpes virus, like modified herpes viruses, right? And so all of this is to say that there's probably going to be in the future a lot more combination with proven known effective therapies like Y90 or TACE. And then also in the future, intraarterial immunotherapy or percutaneous injection of some sort of immunomodulating factors is how I view it. Yeah.
Yeah.
What do you guys?
No, I think that was great. And I mean, that's where the data is. And I agree that at Ochsner, we're very similar to you guys. And, Tyler could speak on behalf of us using way more, radioembolization than chemoembolization. But we are doing a lot of combination. I would say the folks that we kind of considered, and obviously BCLCC, but in the BCLCB area are exactly what you alluded to earlier. If we know a patient's really not on a transplant route, then we're much more comfortable introducing immune checkpoint inhibitors earlier on in their disease course. And then, if we see a patient who's gotten a Y90 or two, and you kind of see the disease is outpacing the ability of the local therapies to control it, I think that's when we're also saying, hey, this is, or if it's a giant tumor and maybe they don't have vascular invasion yet.
Exactly. May not be strong enough, then we definitely feel very free to add on some systemic therapy.